So, good. All right. Newborn screening for MLD. Yeah, so it started in my lab about a decade ago. So the hard part, we had to get, so for lots of reasons, we decided to measure sulfatide levels in dried blood spots. The enzyme's not very stable, so we don't measure that first tier. We can talk about that later. The assay of the enzyme's a little harder, so. The hard part is we have lots of data. Sulfatides are elevated in urine from kids that have MLD. And then we got blood spots from older kids that were diagnosed with MLD and they had elevated sulfatides. But what really matters, and you can't cheat on this, is you need newborn blood spots because sulfatides go up with age. So somebody says, oh, the sulfatides are high in blood spots, it's going to work for newborn screening, and they're older patients. It means nothing. And you say, well, I can't get newborn patients. It means nothing. It doesn't change the facts. So we had to work with the MLD Foundation and contact families that had MLD kids and go back to California and New York, get the dried blood spots stored in the freezer. That's why it's so important to store these blood spots. And if they destroy them all, it's game over for advancement of newborn screening, period. So we have to make sure these blood spots are not destroyed for stupid political reasons. Really big problem. So they're elevated above the normals, but there's overlap. The upper end of the normals, a lot of overlap. It starts out about 0.7% overlap. So 0.7% of random newborns would have sulfatides above this cutoff that we catch all the MLDs. This is these many. We actually looked at 17. They're all above this cutoff. It's just not shown in this slide. So we ended up out of 29,000. This is de-identified pilot study, which doesn't count towards a rough nomination, but it shows that the assay works perfectly well. We found a kid that has MLD for certain. Let me show you. So we ended up doing 200 ARSA assays out of 29,000 at 0.7%, and one had 0% ARSA activity in blood spots, and one had 8%. 198 had greater than 30%, could not possibly be MLD. And the DNA third tier on the 8% showed a false positive. The DNA on the 0% showed a genotype that was reported in the literature as MLD causing. So we're certain this kid will develop MLD, even though we've never seen the patient. I think most people would agree to that. Some doctors would say you never know until you see the patient, but it's pretty good evidence, right? So the false positive rate is very low, 1 out of 29,000. Okay, it's about the best performing newborn screening assay ever developed. Okay. You need to do second tier ARSA as part of newborn screening, just like you need to do cytosine as part of newborn screening. It's madness not to. And okay. A little bit of technology. So you cannot do, a lot of people do flow injection mass spec for lysosomal storage diseases and other things, but you cannot do flow injection for MLD. You cannot measure sulfatides with flow injection. It's been proven in several laboratories. You need to use LC mass spec, liquid chromatography mass spec. But so I think now, it's time to upgrade flow injection to LC, and you have to do this for MPS2 unless you do the fluorescent assay. But MLD will be the straw that breaks the camel's back. It will have to be LC, and all newborn screening labs will be called on to upgrade their flow injection system to LC. I see a world where you have a workstation of flow injection for your amino acid acylcarnitines, and a world where you have a single station of LC mass specs for everything else. And it'll just have to be that way, or you can tell the families that you're not going to screen for MLD with such a good treatment. That would be a shame. So I don't like that. And fluorescence cannot do it. So it's the end of fluorescence, I think, in lysosomals. It's almost over anyways. Next slide. Now, this is an 18-plex. This is way beyond what's on the RUS, but this is 18 diseases, including all MPS disorders, right? Not just 1 and 2, which are on the RUS, but all of them, 3A, B, C, D, 4A, 4B, 6 and 7. We have treatments for a lot of these, and maybe we'll start screening. Also, Niemann-Pick ABC, Niemann-Pick C, we might have Gaucher, Fabry, Tay-Sachs, Sandhoff. We don't have treatments yet, maybe in development, but CLN1 and CLN2, CTX, which I think is coming to the RUSP in a few years. So this is an 18-plex, but there's no reason you can't stop at 18, have to stop at 18. I think this could handle 100 diseases if you have good biomarkers. Now, the last 5 minutes, Barbara, and I'll stay on time, is this spread to 4 or 5 international pilot studies around the world for MLD, okay, with the help of Orchard. And in Manchester Children's, they did a mini pilot on 4,000, and they provided 23 additional newborn blood spots. I don't know where they got them. They had them in their clinic. Additional newborn blood spots from kids with MLD, 23, and 2 of them would have been missed by my cutoff. Okay, so that's the way it goes. And I salute their results. So we lowered the cutoff. And we also noticed that we measure sulfatides have different molecular species depending on the fatty acid attached. There's about 24 species. 8 of them are in blood, 24 in urine. But the 16.1 OH species, we measured the 16.0 species. They noticed that this was a little bit more discriminatory. And in fact, we had this data all along, but we didn't have an internal standard to measure it accurately, so we didn't really report it. But 16.1 OH, you can see the normals and the MLDs, they're better separated than the 16.0. You see the overlap here. And 16 OH and 18 less good. The sum of the 4 is less good. So we entertained the idea that we would look at 16.0 and 16.1. And 16.1 is a better species, but for the time being, we're going to look at both. So all the pilot studies had a meeting a year ago, and we decided what happens if we looked at both species. It's very simple. The answer is very good. Let me see what's going on here. Yeah, if you look at 16.0 and 16.1 above their respective cutoffs, we would see 0 false positives out of 592. Manchester would see 0 out of their 4,000, 3,687. France would see 2 first-tier false positives out of 5,000, and most informative, I think it's Germany, 126,000 would have 39. But look at, this is down from about 10-fold lower than if you just look at 16.0. So the good news is that the number of ARSA assays drops from 0.7% to about 10-fold less. Actually 0.031%, more than 10-fold. So now we decided we're going to make proper deuterated internal standards for 16.0, 16.1 OH. They'll be available from this new company, Gelb and from Revity. We're working with Revity, and we're providing QC samples. The CDC is making QC samples. So, so the algorithm will be to use 16.0, 16.1 OH sulfatide first year. 0.03% come back ARSA as part of newborn screening in blood spots, and then DNA as part of newborn screening in blood spots third tier for the labs that choose to do that. But the false positive rate, I think you need DNA also. And then we think you'll have essentially no false positives. I would say 0 right now. The number is 0, but you know, it'll change, but it's going to be really low. It's 0 right now out of 300,000 in Germany. Let me say it again, 0 false positives if you do this. Okay, it's remarkable. And that's the algorithm. And just to end with, we have a pilot study in Manchester. They're gearing up for a larger pilot study. England, things move a little slow. They have 12 conditions on their panel. They're very optimistic about adding MLD. In France, we have Sumaya Bekri in Normandy is going to go live soon. Germany is live for about 20% of Germany is live now for MLD, and Austria signed on for live newborn screening starting now. La Marca in Florence is starting a pilot, Saudi Arabia pilot, and Wasserstein has the Screen Plus prospective pilot study she's up to 25,000. And now Barbara's going to tell you about the advancement to a RUSP application. Thank you.
Thanks so much, Dr. Gelb. All right, we're just making a quick laptop switch.
Thank you. All right, great. Well, we thank you, Mike. I mean, of course, we wouldn't be anywhere without the pioneering work he has done in developing the assay that makes newborn screening possible. Let me apologize for my voice. Of course, I've got either an allergy flare up or something else going on. Plus, I got here at 4:30 this morning, so not at my absolute peak. And that's not me. No. It should, I did, a Burton, wait, go down there, Burton. Yeah.
Presentation folder on the laptop. Right here. If you go to presentation.
And this is Burton. Okay, there we go.
Turn on the mics.
Perfect.
Make sure we're in the right audio.
We just had to switch.
Okay, great. All right. So I'm just going to expand a little on what Mike has told us. And of course, we ask for every disease where we think about newborn screening, why newborn screening? And usually the answer is exactly the same as it is here, because it's a treatable disease and treatment is only effective or is maximally effective when given prior to the onset of disease manifestations or early in the course of the disease. And miraculously, MLD is now a treatable disease. I think many of us have seen this devastating progressive neurologic disorder leading to death in early childhood over the years. And it is incredibly miraculous that now that doesn't need to happen. So the argument for newborn screening for MLD could not be stronger. You know, it's as strong as any that I've ever seen in my career. We know that treatment for most patients diagnosed after the onset of symptoms is really not efficacious. We really don't have effective disease modifying treatments for patients once they've developed symptoms with the early onset forms of MLD, and that's the target of newborn screening. So this is much like Krabbe disease. We're distinguishing between early onset and late onset disease as our disease target. And it's also like Krabbe disease in the same way that with the early infantile Krabbe, our disease modifying treatment is not effective after clinical symptoms. Same now for MLD. So what is the treatment? Just this past year, the US FDA approved an ex vivo lentiviral mediated gene therapy for MLD manufactured by Orchard Therapeutics. It goes under the name LenMelD in the US. It was approved earlier in the EU under the name LibMelD. The generic name is very long. It's adadarsigene auto something. You can just call it Arsa-cel treatment for short if you don't want to use the trade name of LenMelD, but it's indicated for patients with pre-symptomatic late infantile or early juvenile MLD or early symptomatic early juvenile MLD. It's not indicated for the late onset forms of the disease, which would be late juvenile / adult onset MLD. There's no data in those patients, and like Krabbe, that those patients are much more variable in terms of their rate of progression, their age of onset, and the clinical picture of the disease. So this is for the early onset forms, which include late infantile and early juvenile MLD. Late infantile typically presenting before 2.5 years of age, before 30 months, and early juvenile presenting clinically before 7 years of age. So Len-MELD works basically like what you heard about with ALD. It's ex vivo gene therapy using the patient's own stem cells that then receive the normal copies of the ARSA gene, but those genes are overexpressed so that you reach very high levels of enzyme activity in the patients who are treated. And that presumably is the reason why, or the main reason why this is so efficacious, whereas ordinary transplant is not very efficacious in the late infantile form, even in the pre-symptomatic patient. Some efficacy in the early juvenile, very early treated, but certainly not like what you see with the data here. And we don't have time to go through the data for Len-MELD, but I'd encourage you, if you're not familiar with it, to look at it because it blows you away. I mean, it is really good. There are kids with late infantile MLD now walking and talking and going to school and playing baseball with their classmates when the usual patient is completely paralyzed by 4 to 5 years of age, can't walk, can't talk, can't move. So it is truly an incredibly efficacious disease modifying therapy, but again, only in these pre-symptomatic patients. Because of the way it's given, treatment can only be given in certified treatment centers. So right now, Paul Orchard has the only one, I think, up and running in the US. So patients can go there, and there are 4 others that have been identified kind of scattered around the country where the patient will be able to receive this. So what other therapies do we have? Well, we have had historically hematopoietic stem cell transplantation. If we had a sibling, for example, younger sibling identified, doesn't have the same efficacy as for Krabbe, but it has been done. And in the older patients, that is still a therapeutic option. And of course, even in our clinically diagnosed patients, it's not fair to say that there's no treatment. Of course, there is treatment. We have supportive treatment, palliative treatment, treatment to try to allow the patients to live their best possible quality of life for as long as possible. We did have an intrathecal trial of enzyme replacement therapy ongoing. In fact, it's still ongoing with Takeda. The data have read out, and it showed no efficacy in terms of the disease features that were targeted in the trial, which was motor dysfunction and motor deterioration. There was no difference from the natural history data in the patients who were treated, even at a very early stage of their disease, where they were stage 1 or 2, still ambulatory. However, there's been a lot of pushback to discontinuation of that trial, with some investigators and some family members feeling that there could be efficacy in other aspects of the disease aside from motor progression, cognitive, and others. So right now it's still ongoing, but no new patients are being recruited into the trial. The patients who are in the trial are still being treated as long as they want treatment, and it's really not clear at this point what the future of that is. So the status of newborn screening is that we don't have any states in the US currently doing newborn screening for MLD. We do have the prospective program in Germany that has provided some nice data, and they published a series of 109,000 infants screened with 3 cases of MLD detected. 2 of these were predicted to be early onset and received the ARSA-cell gene therapy. 1 other was predicted to have late onset disease, and HSCT is planned for that patient. Since that publication, they've identified a 4th case with early onset disease, and that patient has received ARSA-cell treatment. So their experience suggests maybe MLD could be a little bit more common than we had suspected earlier, but of course it could just be statistical fluctuation, and it may not be the same across all geographies. So we really won't know until we start doing it in the US, but the German data has been very important for moving the needle forward in the US. There are several states now in the process of setting up newborn screening. We were very happy in Illinois to get legislation passed in 2023, anticipating the approval of MLD to mandate the addition of MLD to our screening panel. We are hopeful that that will start in September of this year, so very soon. And there are several other states now in the process of looking at this or taking a vote on it. Their committees are assessing it. So hopefully some other states will begin. And in addition, an application has been recently submitted to get